Okay, greetings, everyone. Can you hear me okay? I'm sorry, 1 second, please. I need to switch something around. I apologize. I need to work out some technology over here. Um, oh, I'm sorry. Trying to find my, trying to pause sharing. Okay, let's see if I can.
Tiffany, do you want us to show the slides from here?
I'm very sorry. I'm trying to get things set up so that I can have my presenter view.
Do you want us to show the slides directly from here and you tell us to move forward or not?
Sure, that'll be fine. Thank you.
So just put on your webcam and we'll take care of the rest.
Thank you. Okay, well, while we're getting set up, I can go ahead and begin with my introductions. So I just want to first again, thank you for, just want to say hello to everyone that's in person and for virtual attendance. I bring you greetings from Atlanta, Georgia. My name is Tiffany Aholu, and I'm a behavioral scientist at the CDC in the Division of HIV, Global HIV and TB, and HIV Prevention Branch, where I serve as a HIV testing services technical advisor and the branch's faith and community liaison for reaching men and children with testing and clinical services. I'd like to start by sharing the agenda for today's session. I need to make sure I can see where we are. Please bear with me. Okay, great. Okay, great. So we are on our agenda. So we're going to start with opening remarks. I'll speak a little bit about the Faith and Community Initiative, Messages of Hope. I'll do an introduction of our presenters, which will be, well, we have a discussion on faith matters, the congregational baby shower model, Ugandan experience, and then we will have a live virtual Q&A with Susan Hillis as our facilitator. Next slide, please. So PEPFAR's success has been built in partnership with community, including our religious leaders, our faith-based organizations, and other faith and traditional communities. PEPFAR recognizes that leveraging the extensive relational and social capital of faith and other communities will result in greater progress reaching and sustaining the goal of HIV epidemic control. It is for this reason that in 2018, the United States government, through the PEPFAR, invested $100 million to address key gaps towards achieving HIV epidemic control and ensuring justice for children by leveraging the unique capacities and compassion of faith-based organizations and communities. We had 10 countries, FCI countries and investments during COP19, and those countries included Botswana, Eswatini. The Lu Commission was one of those recipients in towards that initiative. We had Haiti, Kenya with EDARP, Lesotho, Malawi, Uganda, Tanzania, Zambia, and Zimbabwe. There were others. That was some others that was also supported through the CARES Act for COVID-19. Yesterday, during the closing session, some of you may have heard Susan Hillis highlight some impressive data, and even today, as she highlighted the Circle of Hope, impressive data from some of our faith and community initiative best practice models. Today's presenters will expound on ways in which the Faith and Community Initiative has leveraged faith-based organizations to accelerate epidemic control by tackling HIV stigma and discrimination across different populations. I will begin by briefly highlighting the Faith and Community Initiative messages of hope. Next slide. So yesterday, both Francesca Miracle and Susan Hillis both touched on the messages of hope in their respective presentations. Therefore, I will keep my presentation brief as it relates to the messages of hope. First, wanting to start out, the Faith and Community Initiative recognizes that faith leaders have an important and unique role to play in stopping the spread of HIV by sharing messages about the value of testing and of adhering to treatment, by building strong relationships with families and partners, and by impacting their communities with stories of hope. Next slide. The communication prototypes and assets that incorporate messages of hope and information on HIV to change norms and enhance demand creation for appropriate and targeted testing, including HIV self-testing, linkage to treatment and retention and care with a special focus on men and children. The HIV messages of hope are integrated into sermons, educational talks, homilies, reflections, prayers, and other religious materials for use in churches, mosques, and places of worship. The messages of hope on COVID-19, they aim to accelerate community mitigation of the impact of COVID-19 by engaging effective key national influencers and faith leaders to help communities rapidly accept life-saving aspects of behavior change that are urgently needed in the areas of physical distancing, hand hygiene, covering of face and mouth, quarantine and isolation measures, among others. And by engaging faith leaders and communities in dissemination of key COVID-19 mitigation messages, along with messages of hope, both within and beyond the faith structures, we hope to increase the uptake of targeted COVID-19 behavior change strategies. Next slide. Trusted faith leaders, they can take innovations and solutions to their communities to address the core gaps in testing and treatment. Next slide. Now, over the past few years, several faith communities and faith leaders from the 10 sub-Saharan countries that were funded through FCI have been involved in discussions on how to end the HIV epidemic and ensure the future health of our children, adolescents, men, and children. These examples of faith messages are the result of both the research and the critical discussions during which these local leaders have proposed community-based ideals and solutions. In this example here, you'll see the first one here is my reasons for getting an HIV test, my reasons for staying on HIV treatment. Then this is one about your family's hope and dreams are worth living for, and then about love yourself to love others. These are some example message of some of our messaging. Next slide, please. Bring hope to your family. Next slide. I like this one, especially given the some of the comments that we've been talking about in terms of children and the role that faith leaders can play. Here at the bottom in this left corner, we see an example of where messaging is geared towards reaching children. When religious leaders, when they speak these messages to their congregants, they are playing a critical role in helping to normalize the importance of reaching children with life-saving testing and treatment. And again, because children are unable to go and seek these services for themselves, this is where it's really important that the faith leaders are speaking these messages to the parents, to those guardians who can really ensure that the children are getting tested and treated and helping to normalize that. Next slide, please. Here, there's a full suite of materials here that's on the Faith and Community Initiative .org website, where there's some messages that can be used for WhatsApp and SMS. Next slide. Here are a few examples of brief messages that can be shared as a text message, a tweet, or even as an image on WhatsApp. Next slide. So when we ask what can faith leaders do? Well, faith leaders, they have an important role in stopping the spread of HIV and stigma for that matter. They can encourage people to get tested. They can encourage people living with HIV to take their medications. advocate for care and prevention for those living with HIV. They can pray for physical and emotional strength of those affected by HIV and call on communities and families to support people living with HIV. And on the site, there are additional resources for faith leaders to know how they can use these messages of hope and what they can do. Next slide, please. Now, yesterday, our PEPFAR ambassador, Dr. John Kengasong, he shared an example of the critical role that religious leaders played in promoting the uptake of COVID-19 vaccines in several countries in sub-Saharan Africa. Likewise, the FCI Messages of Hope for COVID-19 equips faith and community leaders with messages to encourage mitigation messages and support vaccine acceptance. Next slide. Here you see different messages, again, that can be posted and shared within the church and the sermons on different media platforms. And lastly here, now that I've shared, these are some examples of flyers and prayers. So now that I've shared how messages of hope can be used to reduce stigma and discrimination by normalizing and creating a demand for HIV testing, treatment, adherence, and COVID-19 vaccine acceptance, I'd like to shift the attention to our panel of presenters. Next slide. So first we'll have Ms. Yvonne Pandey of Expanded Church Response, and she'll present on Faith Matters. Next, we'll have Timothy Ifuntwe and with CDC, and Dina Patel from USAID. They'll present on the Congregational Baby Shower Model. And then lastly, we'll have Justice Muhanji of Uganda Catholic Medical Bureau, who present on the Uganda experience. And their pre-recorded videos will play in this order and will be followed by question and answer led by Susan Hillis. So without further ado, I'd like to turn the floor over to our panel of presenters.
I'm Yvonne Pandey. I'm going to do a presentation with our experiences on the Faith Matters program as Expanded Church Response, specifically on overcoming HIV-related stigma and discrimination relating to adolescents and young adults. So before I talk about Faith Matters, I just want to briefly talk about Expanded Church Response. So we are an organization who consider ourselves as a PEPFAR success story, being an organization that really started very small and also now having to grow into an organization that is able to receive direct USG funding and moving from a budget of about $35,000 into managing budgets of over $32 million US. These are in PEPFAR grants. We've moved from providing commodity grants into implementing evidence-based approaches, including DREAMS, No Means No, coaching boys into men, and the likes, building the capacity of over other 100 local FBOs and CBOs supporting hundreds of thousands of adolescents and their families. About the Faith Matters program, really this is a 2-day specialized workshop with specific curriculum that brings an understanding of faith core values and purposes to help faith leaders embrace and effectively apply evidence-based approaches to affect positive outcomes for adolescents and young people. This particular curriculum comes with a toolkit which we give to the faith leaders so that they can have information and continue improving their knowledge and be able to support these adolescents. So this toolkit contains information such as HIV stigma, PrEP, HIV testing, post-rape care, and the like. Some of the goals of the Faith Matters program includes providing an overview to the leaders on the pressures that adolescents and young adults face, but as well as giving them information on HIV and related topics. They also try to share information to community leaders for them to understand and prevent child sexual abuse, basically emphasizing the role that they have in supporting and guiding these adolescents and young adults. So our strategy as Expanded Church Response basically is to use these faith-based institutions, which are arguably the most trusted, influential, geographically accessible, well-networked, permanently embedded institutions who brings people on a weekly basis, on a daily basis, who convene there and give them information. So the idea is to ensure that when the faith leaders meet these people, these are the people that go back in the communities. These are the people that are found in the markets. These are the people who go back and are found in the schools, in the health facilities and all. So basically this brings up about a transformation strategy where the Faith Matters program is passionately embraced and spread by the people across communities, bringing about a sea change of positive attitude and behavior change. So as ECR since 2018, we've trained over 5,000 faith leaders in the Faith Matters program across 14 districts of Zambia, representing the faith mother bodies at national levels, coming from those represented by the Christians and also those represented by other faiths such as the Hindus and the Muslims. We've reached over 2,089 denominations just in the past 2 years where these faith leaders are coming from. The types of the faith leaders that we've been able to train include both men and women. They are priests, they are reverends, they are pastors, they are Sunday school teachers, youth leaders, etc. So we've trained more faith leaders of the Christian faith because Zambia is predominantly Christian. Over 95% of the people in Zambia associate themselves with Christianity. So some of the impact that we've recorded through pre and post interventions, assessment, as well as review meetings include members reporting that they are more aware on how to deal with HIV stigma. They've reported increased reports about sexual GBV disclosure by congregants and communities. We've also faith leaders who've reported increased confidence in terms of dealing with HIV testing and medication, and just the community members being more aware about the myths and the misconceptions on HIV and AIDS. We have reported an increased number of other faiths that have been able to participate because Zambia is predominantly Christian. Sometimes these different faiths wouldn't meet in the same places, but it's good to note that we have different faiths having meetings, being trained together in the same communities coming from the different faiths. We have community members reporting being more aware of child sexual abuse, and also faith leaders reporting increased confidence on how to engage the youth on sex and sexuality issues. We have some of the impact reported, which includes some of the testimonies that we've gotten from these faith leaders. Mohammed said, our men initially refused to participate in a Christian-led project, but some said, let's give ECR a chance and see. We found that they do not even have a judgmental language, but guided us on how we can help our people get tested and adhere to medication. Now we do just that. This is impressive. Sister Marlene Piri from St. Oscar's Parish said that she wasn't sure that the Faith Matters took it to be of great help to her. And she said, I should confess that the materials is well laid out, and I did indeed meet my expectations, and has made my weekly Tuesday community visitations a lot easier and enjoyable as we engage our communities on stigma. The other quote from Father Reverend Mwanza of Reformed Church of Zambia said, the Faith Matters training was an eye-opener to us in tackling issues of stigma and discrimination. So many have been encouraged to adhere to medication, and it is working. Reverend Piri of the Council Churches of Zambia said, the Faith Matters toolkit has been a blessing to us, especially as we use it with the student clergy in our congregation, an opportunity that I personally didn't have. The students are very appreciative of this initiative, and it is believed that their approach to these matters when ordained will be better than our time. With this knowledge, that's what Father Piri, Reverend Piri said. And this other quote was from the facility in charge at the health center, who said many of these cases of HIV testing we've done in the past or two. We've had clients who said it's because they came from this church or the other. And when they inquired further, they found that these churches were working with expanded church response. And in turn, they reported increased numbers of clients who are turning up for HIV testing from these churches. So thank you very much. We are now open to comments and questions. Thank you.
Good afternoon, Good morning. My name is Tim Adiola Efuntoye. I work for the U.S. Centers for Disease Control and Prevention. I am a physician by training, and I am a team lead clinical services prevention branch. So this afternoon, my colleague and I will be sharing our research and program implementation experience on baby shower in Nigeria. I'll turn it into my colleague, Dina, to take it on.
Hi, everyone. Good morning, good afternoon. My name is Dina Patel. I'm a pediatric nurse practitioner by training and currently serve as the Senior Technical Advisor for the Pediatric and Maternal Child Branch at USAID. So I'm going to jump right in. We're going to be talking about the Baby Shower Initiative. The Baby Shower Initiative was initially funded by NIH in 2012 as research to the PI Dr. Azana Lue to address the increase in number of perinatal HIV transmission in newborns in Nigeria. At the time, sub-Saharan Africa accounted for 87% of women living with HIV and 91% of children living with HIV worldwide. That amounted to about 210,000 new HIV infections in children globally. Nigeria, along with India, accounted for 90% of all pregnant women infected with HIV. The testing rate was less than 20% among pregnant women and accounted for 26% of all new infections. This was largely due to where women were receiving prenatal care and where they were delivering. Only 35% of women were delivering in a health facility, and only 2.9% of the facilities had established PMTCT programs. The barriers were stigma associated with HIV-only testing sites, identification of pregnant women, access to testing, and linkage and retention in care. Baby Shower Framework addressed each of these barriers in a unique integrated way, reducing stigma associated with HIV testing. It was a fun way to take charge of your own health. There were 3 phases of the baby shower. The first phase was a prayer session where the priest would call all the women and male partners to the front of the church, identifying all pregnant women and the male partners in the community. The priest would pray for the health and safety of the pregnant women and their families. The second phase was the baby shower, where we would celebrate the pregnancy by dancing, eating, providing education, and on-site testing for HIV, sickle cell anemia, syphilis, malaria, and hepatitis B. It was an all-inclusive for pregnant women and their male partners to address critical health needs during pregnancy, including HIV. The third phase was a baby reception, a celebration after baby was born, utilizing the church gave an opportunity to follow up with mom and baby to ensure there was no loss to follow up. The results showed that there was a 92% increase in the intervention group where baby shower took place, but only 54% of women were tested in the control group. There was also an increase in the number of male partner testing as well. As I mentioned before, the baby shower has a very unique approach where it focuses on the importance of an integrated health promotion approach, not just for HIV, but other health disparities. Even though the goal was to see if we could increase HIV testing amongst pregnant women, it was to promote overall health for mom, baby, and the dad. The platform also has been used for mental health screening, pandemic outreach, cervical cancer screening, and family planning. And it can definitely be used for other health-focused areas as well. We had over 25 different publications that was from the original baby shower study. They were evidence-based and peer-reviewed publications that focused on areas that the baby shower had a positive effect on.
So thank you very much, Dina. You've made my work quite easy. So the background of Nigeria PMTCT program is presented here. It's been talked about by Dina extensively, but I wanted to pay attention to the fact that Nigeria has an annual pregnancy of 8.5 million, and we have a mother-to-child transmission rate of 22.156%. So we went ahead to select State of Benue for implementation of baby shower. And we actually picked 77 churches, which were selected based on the capacity of the church and some other additional across 12 local government areas in Benue State. So the chart on the top left indicates the map of Nigeria with Benue indicated in black, dark color. And then the center of the chart is a map of Benue State with the local government where baby shower was implemented showing up. So we selected 77 congregations and enrolled them based on capacity and willingness to be part of our program. And then we also looked at the congregational size. We also checked the accessibility to health facilities so that referral can be quite easy. Data collection tools include just a questionnaire for all participants where demographics was taken, and then pregnancy and HIV testing history was also elicited. And then we took blood samples for HIV testing, hepatitis B, and sickle cell. And then we ensured that the church health assistant was able to follow up with every positive and ensure linkage to treatments. And I won't want to go through the framework for baby shower as presented earlier by Dina, because that actually took place for every of those selected community. And then the data management was through a descriptive analysis in a startup 14. And then we'll also have the baby shower and linkage database merged so that we ensure that the data is validated. And then we'll compare the baby shower results to PEPFAR program data for Benue State for the same period of time. So what were some of those findings? Out of the over 10,000 pregnant women that tested at baby shower events, 61.5% of those attended with their spouses who also tested, which is quite high compared to what PEPFAR program produces every year, which is less than 10% of partner testing took place at ANC. And nearly half of the female participants that were not enrolled in ANC for the current pregnancy, meaning that it also serves as a platform for testing and reaching out to women that are not being tested over the years. And then we have a 22.3% of female and 24.8% of male participants reported that they had never been tested for HIV before. And then over 99% of participants had their HIV status ascertained. While female had 7.2% positive, we had 4.0% positive for male. And then we had 2.9% for female and 2.3% of male receiving new HIV positive diagnosis. And above all, we also ensure that 93% of those that were positive were linked to ART. And this also emphasizes the fact that a higher proportion of pregnant women were newly diagnosed of HIV positive in baby shower as compared to health facilities. So what were some of those conclusions? That baby shower were translated from research to real-world implementation across multiple sites with standardized implementation monitoring tools. And then a baby shower were well attended, including by vulnerable population with low ANC attendance. And the acceptance of HIV testing was nearly universal, and a higher proportion of pregnant women were also seen to be newly identified as HIV positive at baby shower as compared to the health facilities. So identification of HIV positive in women was one area where baby shower also provide opportunity to achieve, and then linkage of HIV positive pregnant women to ART, and then male case finding was also quite high, and has continued to be our approach. So what's the next steps? Implementing baby shower in a strategic setting in Nigeria is what we're doing right now, particularly deploying as a component of our AP3, accelerated progress in PMTCT and pediatrics. And then we want to adapt baby shower principles in Muslim community and in mosque, which has already started. And then conduct analysis of cost and share in the public domain for other countries who would want to follow suit. And then finalize and publish the baby shower toolkits, which is in the final stage, so that other countries can also learn from this. And for additional resources, this will be quite useful. So thank you for your audience.
Huge thanks to all the presenters. I know you really wished you could have been here, but we are so thrilled. It came out great, you doing it online. So unfortunately, we are quite behind, and so we only have time for one question. Is that right, Francesca? And I'm going to just take it from the room if there's anyone. I'll answer the one online, but what about anyone in the room have a question for any of the specific presenters? Yes, go ahead, stand up, please. Maybe you can take your mask off because it's so hard to understand people through their mask. Great.
I was wondering if the baby shower was only for married couples, or
No, anyone can come. You know, it's so interesting. It was tested in the Catholic Church, and the way the priest described it was, you know, all the women who are pregnant come up to the front, and any men here who are the fathers of these children also come up to the front. So yes, it's for everyone. Other questions? That was so fast. Am I missing somebody? The one online. We were talking about faith leaders supporting stigma reduction. We know many faith communities are the source of stigma. Many parents don't want their children to be on treatment. And the reason they don't want them to is they're afraid the faith communities will know their children are living with HIV and judge them. So let's hear, I would think that Dina, you and Tim would be great to answer that question. So can one of you go ahead, please? I see Tiffany's coming back on, but I actually think this is probably for Dina. There you go. Go ahead, Dina.
Everyone. Yeah, thanks for the question. So the way we had done it was that everybody for baby shower was counseled. So it didn't really matter if you were positive or negative, but everybody was given that specific information on where to go if you were positive and what resources were available. And if they were positive, we identified one person within the church who could then follow up with the families more on one-on-one. So the priests and the faith leaders didn't know who was infected in the community.
Great. Okay, thanks so much. So there was confidentiality was preserved, basically what you're saying. Great. Thanks so much, Dina. Okay, there's Francesca's breaking the rules and letting us go a little farther. That's great. Go ahead, Jane.
Thank you so much. I think one of the lessons we have learned from FCI is documentation and the power of documenting the interventions that we are undertaking as faith communities. And I know over time we have been accused of not showcasing whatever we are doing. And I'm wondering, going forward, is it possible for UNAIDS to continually provide technical assistance to faith communities so that we can continually show what we are doing? And this doesn't have to be, like all the time, every other quarter, but maybe by annual reviews or evaluations of the work that faith communities are doing at the country level, at the regional level, and sharing with the world, because we are doing an amazing job. Thank you.
Great, thanks. I will say one thing that I really would encourage you all to think about, and that is everything in PEPFAR revolves around 95, 95, 95, and we know that. And the things that we have been talking about showed marked preferential performance of the faith groups compared to the non-faith groups in especially the first and also often the third 95. So those are things that we definitely need to document, and so I appreciate that. And I know that we also, Julianne had a suggestion for me. All of these effective programs are well documented in the COP22 guidance that's publicly available online, but that document is 756 pages long. And so so Julianne was saying, like, nobody is going to, who's going to wade through that to try to find it? So one of the things we do need to have some conversation about later is these effective models, we need more and more political will to support them, and so it needs to be easy for the faith leaders and advocates to know what they are. So that's something that I think Francesca and Jacek and Julianne, like, we all need to be, and Father Bob, we need to be more conversation about how do you make what works more, raise awareness about it and make it more accessible. Thank you so much, and I guess we go to lunch? Sorry, those online, we wish you could join us. Okay. Well, go ahead and make your announcements, whatever, Mark?
Yes, we will reconvene in at 1:30, so in 45 minutes. For those online, 45 minutes. Thank you.